Thank you for joining us today. I am Michael Schneider, a member of the class of 73, as well as a member of the School of Medicine and Dentistry class of 77. I am located in Rochester as a professor of clinical medicine at the Medical Center. My U of R alumni activities have become a very important part of my personal commitment to the university. I am the immediate past president of the School of Medicine and Dentistry Alumni Council, and am presently a member of the Alumni Board, the host for today's Rochester Experience event. The Alumni Board is a group of 25 alumni members representing each of the university's academic schools. The board is chaired by University trustee Lizette Perez-Disbach, class of 87. The Alumni Board's purpose is to encourage and lead all alumni and students toward a lifelong connection with one another and with our university. Today's lecture is part of a new series called Experience Rochester and directly exemplifies the university's commitment to lifelong learning. This series will feature topics and speakers that are unique to our university. Today, we do have a wide range of participants joining us for the session, including students, parents, and alumni from as far back as the great class of 1957. A few important tips to make your Zoom webinar experience efficient. If you would like to ask a question, please submit it through the Q&A function that is located at the bottom of your screen. Dr. Scharf will answer questions at the end of the presentation. To view this session with closed captions, click CC on the bottom toolbar and select Turn on Subtitles. Finally, if you're having trouble viewing the webinar by video, please call in and listen using the phone number that was supplied in your confirmation email. It is my pleasure to introduce today's speaker. Dr. Michael Scharf is Chief of Child and Adolescent Psychiatry and Director of Psychiatric Graduate Medical Education at the University of Rochester Medical Center. Dr. Scharf is a founding member of the Rochester Youth Violence Partnership, a hospital-based violence intervention program. He is also the local site leader for Project Teach, a New York State program to provide education and clinical consultation to primary care doctors as they care for the mental health needs of children. After Dr. Scharf's presentation, Jennifer Johnson, Director of Family and Community Outreach at Golisano Children's Hospital, will join him for a moderated conversation. They will answer questions from the registration forms and those that participants submit in the Q&A box. Thank you again for joining us for Experience Rochester. And now, Dr. Scharf.
Oh, it's a pleasure to be here today and in front of this group. I am Mike Scharf, as introduced, and I'm going to talk today about our children's mental health during these challenging times. And to do this topic justice, I'll give some background about the behavioral health crisis facing children and families before what's on most of our minds is the current stressors and crises related to the pandemic, and as well as some of the civil unrest and all of the uncertainty happening right now. And as mentioned, have plenty of time for questions. I've tried to include a lot of information in the slides, and I'll go through some of them quickly, but they'll be available as a resource. And I've also tried to stick to general principles, looking at the first questions that have already come in. There's quite a diversity of interests and questions, and I'll do my best to answer as many as I can. I do have one disclosure. Some of the slides at the end, the last 5 slides, were actually developed by and with one of my colleagues in behavioral health, Dr. Linda Alpert-Gillis, here at University of Rochester. So again, the background, the context. I list on the slide here some of the things that have really become kind of the background that I start every morning with for the last few years. It's true that 1 in 5 children would meet criteria for a mental health condition as defined by a number of surveys that have been done, and the disorders that are defined in our diagnostic and statistical manual. Now that's all inclusive. That would include depression and anxiety, which many people think of as behavioral health conditions for children, but also autism, ADHD. Again, in the most generic terms of behavioral health, 1 in 5 kids have a significant behavioral health condition. And these conditions are the top 5 causes for disability in youth and have been for the last 15 years. And looking at it from a different perspective, some of the most significant impairments in adulthood in the category of psychiatric illness, more than half of those have their onset before age 14. And the most concerning outcome in my day-to-day work that I'm trying to reduce and avoid is suicide. And unfortunately, youth suicides have been on the rise, particularly in the 10 to 14 age range in the last 10 years. This is a list of the causes of death, just to kind of highlight that. As you can see, suicide is now the second leading cause of death from ages 10 to 24. And when we think about all of these kids struggling with all of these conditions, it's also true that only 20% of them ever see a mental health provider. At the same time that we're recognizing these problems and we're having increased awareness of the prevalence, we're also having increased understanding of the impact of adverse experiences, of traumas on children that ultimately impact them across the lifespan. The slide here refers to the Adverse Childhood Experiences Study and Growing Data, or ACEs for short. And this is not new, but we're again getting increased attention and understanding to the idea that things that happen, negative things that happen in childhood, not only predict mental health issues and behavioral health issues, but also are some of the most powerful predictive factors for midlife medical morbidity, heart disease, hypertension. And so looking at these problems is not just about emotional suffering and about the behavioral conditions themselves, but also potentially to impact health across the lifespan. As I talk about adversity and talk about stress, it's important to recognize that stress is normal, and feelings of anxiety and sadness, particularly in the face of adversity, is normal. So when we talk about something being traumatic or stress being toxic, it's useful to have this idea in mind that some stress is normal. In fact, if we didn't have any challenges or stress, we wouldn't learn to walk or feed ourselves. So stress can be health promoting or promote growth when it's positive. It can also be tolerable when it's not particularly positive, but it doesn't, we can deal with it. It doesn't overwhelm our coping mechanisms and our ability to tolerate the adversity or distress that happens. And then it becomes toxic and problematic when it overwhelms a child's coping mechanisms, leading to long-term impairment. Now, if we look at that from a University of Rochester perspective, in the University of Rochester Golisano Children's Hospital, the Division of Child and Adolescent Psychiatry, we are the only provider for many levels of care and the largest provider of ambulatory outpatient care for mental health services across our region. And on the slide, I list a little bit of specifics. We have the only inpatient unit with 27 beds, the only partial hospital program actually on the side of the Hudson, New York State, with 22 spots. And we do over 40,000 visits a year in our outpatient service. And as well as a number of prevention programs, contracts with specific services, with court, with probation, with the detention center, school-based programs. And so looking at what we've seen, over the recent years, there's been a tremendous increase in the demand for mental health services. We've had a wait list for our outpatient service was up to 300 families on it, even as we've continued to increase the size of that service. Our wait list for our partial hospital service, which is an alternative to inpatient admission. It's for people who are in crisis and at high risk of significant disability or even death or hospitalization. And we've had wait lists for that service routinely in our busiest times of year, over 80. And our inpatient unit is often full with people waiting for beds in our emergency room or in other emergency rooms in the region. If we look at that emergency room presentation number, since 2015, we've seen the number of children presenting to emergency rooms for behavioral health issues increase by 30%. And again, this is all before the pandemic. So part of our response, and one of the things I'm most excited about that we've been able to do, is through the gracious support of Tom Golisano and a number of sponsors and supports in our community, some of which you were probably on this call, we were able to open a new facility, a building dedicated just to children's mental health. It's the Golisano Pediatric Behavioral Health and Wellness Building. And this building allows us to expand our outpatient services even further by 25%, to expand specific crisis services and to develop a new level of care, an intensive outpatient program, as well as expand that partial hospital program that I mentioned. Unfortunately, this building opened in the midst of a pandemic. It's the only ribbon cutting I've ever been to on either side of the podium where it was done virtually. And I'm coming to you from the building right now. We do have staff on site seeing patients, but it has been not the opening we imagined, and the majority of our care is happening by telemedicine right now. So what happened with the pandemic that impacts children's mental health? Well, there's some things that are obvious, of course, and I list them here. If you recall, in March, schools closing, normal social networks and supports stopping, isolation for youth and for parents, significant role strain for parents. And in this case, I'm talking about having to not only figure out finances and work if you're able to work from home or not, as well as figure out plans to supervise children or even be the teacher or do some of the elements of what teachers in school would do prior to this. There was resource uncertainty. Do people remember when there was times where you couldn't reliably get paper towels or hand sanitizer? There's still intermittently some limitations in resources. And the uncertainty about the disease itself and the anxiety, particularly for people who are already medically at high risk and people who are of racial minorities, low socioeconomic status, seem to be at the highest risk to be impacted by COVID and die from COVID. So we see naturally an increase in stress levels, in what I'm referring to as toxic stress as a result of all of these things. And we have seen increases in some of the things we would then expect, including intimate partner violence, or what we used to call domestic violence, community violence, community gang-related, often shootings and stabbings in cities, and child abuse. In terms of caregivers specifically, this is a particular concern because we're all, as caregivers, as the adults, going through the stressors as well. And parent stress or caregiver stress can negatively impact our ability to parent effectively. And it can contribute to increased intimate partner violence, child abuse, and this has been shown in data following significant losses or disasters that this happens. It can also lead to increased substance use, both in parents and in teens. Now, trying to assess the impact on the child in front of you, on an individual child, different children are impacted differently, and it's impacted by where they are developmentally, both in terms of age, but their unique developmental trajectory, their temperament, their psychological makeup, what their general level of functioning and ability to deal with stress, their coping strategies and how good they are at coping with adversity, family functioning generally, and resources that families have. All of these things impact how children will be impacted and react to the pandemic and the related stressors, as well as their own past experiences of loss or traumas. If you think about that, then of course the responses will vary, and I list many of them here. Sometimes children will articulately say they're worried, they will be anxious. Sometimes children will be irritable and behave or act out in ways that don't seem directly related to the stress, but could nevertheless be quite difficult. They'll sometimes push back on limits and rules with their parents, even as they will verbally say they understand their parents are under more stress. But again, and with all of these stressors coming with the isolation, this is sometimes what we see. They're more comfortable sort of letting their guard down, letting their coping skills down with parents and acting out, showing their distress even more. Sometimes we see difficulty falling asleep or staying asleep, nightmares, Sometimes for younger kids, we see what we call regression, and you can see people that seem to be sort of behaving with one level of maturity kind of come down a few notches. We can also see repetitive play that can be reenacting elements of either what has stressed them out or what happened, or something related to it. And we can even see aggression in kids that doesn't necessarily tie in a logical way to them being stressed about isolation, but nevertheless it can be how they express their distress. So what have we seen here and how have we responded? Well, it has been very impressive to me how our community has come together and how we have really across our region things and services and approaches, even within the helping world, if you will. We've broken down silos and come together to collaborate to try to meet people's needs. And in terms of our clinical services, we very quickly transformed to doing all of our services, or almost all of them, by telemedicine or incorporating telemedicine in some component. And in terms of people seeking new care, our number of referrals for outpatient services has actually been steady. So it has not gone up as much as we might have predicted given all the additional stressors. Our presentations to the emergency room and to the hospital, to be admitted to the hospital, have actually been less. However, what we've seen is those that do present and are admitted tend to be in a more serious state, a more serious condition. So we see less people coming with first thoughts of suicide, more people coming after actual suicide attempts. And if in terms of trying to understand this, then this is based both on sort of theoretical understandings, but also the real experience with the families we're working with and treating. Some kids who are already anxious or having depressive symptoms, the isolation and the closing down of things actually accommodates some of the things that was stressing them out before. And until some of those challenges are returned, they can seem like they're dealing very well with everything that's happening. But then when they try to return to being evaluated by teachers, to having to return to social expectations which were previously stressful, when things that have been kind of creeping along in terms of parents either staying at home or having financial needs met, now it becomes a crisis, then we see the reaction. So again, we've seen a mixed picture in terms of service seeking and service utilization, but with a general theme of when people present, they're more acutely ill or more acutely distressed. We've also seen, and this has been a really neat lesson to learn, that barriers to care are less with telemedicine. Now, saying it like that might sound straightforward, but what we see is it's all the barriers are on the front end. And fortunately, in terms of working with kids, schools did a lot of work to make sure every family has a laptop or tablet in their house so they could access telemedicine services. And so still, again, there's barriers, but once appointments were scheduled, we have very few no-shows or last-minute cancellations compared to our experience with live visits. So there's some opportunities to actually learn from this and provide more care and more effectively use our resources in the future. And I want to pivot a little and talk about what we can do and about hope and about building resilience. Adversity does not equal destiny. For all the concerns that I've been talking about and the picture I've painted and really lived in of a behavioral health crisis exacerbated by the pandemic, at an individual level, adversity does not have to equal destiny or equal a problem. We can balance adversity and ACEs with protective factors, and we can foster resilience. And there's increasing numbers of studies to support that. So what are these protective factors? Well, I list the main categories here. Healthy attachment relationships, that's usually with a parent, is a strong protective factor for adversity. Ability to regulate emotions and behavior so that when you're distressed, you recognize you're distressed, you do something to calm your emotions, and it actually happens. You actually do successfully calm down. Supportive environment systems. Now, these have been challenged with the pandemic. School supports, churches, other groups that youth and family may be part of have been limited. And so that's a challenge, but if we can support those, that is a strong protective factor. And then cognitive factors, particularly around meaning and motivation, can be powerful protective factors. Now, this slide is from Monroe County and spin-off of the Office of Mental Health, CCSI, which do an analysis of the Youth Risk Behavior Survey. Now, I could talk for an hour about Youth Risk Behavior Survey and about this analysis, but the point I want to present here is that they've looked at ACEs and how it correlates with self-report among teenagers of things like depression and suicidality and substance use and coming to school intoxicated. And what they found is confirming, not surprisingly, that having a history of ACEs make all of those more likely. What they've also found is that even among teens who have had 2 or more adverse events or traumatic events, if they also say yes to one of these 3 things, then compared to those who say no, those things I just mentioned of suicidality, drug use, depression symptoms all go down significantly. So what are these 3 things? Well, as you see on the slide, I matter to my community. Having a sense of connection and being a part of and really mattering to community, however one defines community. I have at least one non-parent adult support, or I receive encouragement at school. Now, each of these things are really challenged in our current environment, but they're also potentially really powerful. This is just one example of looking at that analysis and one of those 3 factors. Particularly when youth say they feel that they matter to their community, their reports of having considered suicide in the past year, for those who've had 2 or more traumas, are decreased by 20%. And that's you can see I have 3 spots there: substance use, suicide, and mental health symptoms. And that decrease in suicidal thoughts in the previous year, that's a similar magnitude of impact to antidepressants and some other psychotherapy trials done with high-risk populations. So what else can we do? What things can we do that are helpful to address needs of children and to promote resiliency? Well, these 4 categories is what I would direct people's attention to, and I'm going to go through each of them briefly. And these are the slides that I mentioned were developed with one of my colleagues. Establishing and maintaining routines. When something unpredictable and difficult and even traumatic happens, having an ability to predict what's going to happen in the world going forward is important. And having a clear, predictable routine and consistency is one of the best things we can do to promote resiliency. We all benefit from routines, but particularly children do. And this includes bedtimes, meal times, when school's in session, having a clear schedule, even if you're doing school from home, designated time for relaxing, for exercise, for playtime, and tying together what we call high probability behaviors can reinforce low probability. So if you know someone's going to do schoolwork every day, you tie that to, someone needs to do schoolwork every day, but they don't want to, you tie it to the relaxation or playtime that they're going to be motivated to do every day. And again, this is largely about having a sense of predictability and control in the face of things that you can't control. So anything we can do to help children have an increased sense of control will be helpful. Being emotionally available and facilitating social bonds. So that means listening, really trying to listen, understand what your children are going through and what's stressing them out, and try to be present and sit with it, not give them false reassurances if they're expressing a worry about something that's absolutely real, but express understanding. I can understand why you feel that way, and these are the things we can do. And trying to maintain connections, even if we can't have kids together with other kids, going out our way to make sure that people still have contact time, even if it's through a computer, with their social supports. Coping skills. I mentioned before that if someone has evidence of being able to use coping skills effectively to regulate their mood, that's a powerful predictor of resiliency. And so some ideas about how to do that. Giving people, and you can do this by role modeling it too, that, oh, I'm feeling anxious now, and this is how I'm addressing it. I'm feeling scared, but I can handle it. Anticipating what are going to be the stress points and trying to prepare people for it. Practicing mindfulness. Having a sense of acceptance of your feelings, that your feelings are not necessarily reality. These are all things that can be helpful, as is a regular physical exercise and attention to sleep and nutrition. The last thing I want to include is talk about is explanations. having time to try to explain what's happening, even with the limitations of what you know, can help children have a sense of predictability and that the world makes sense. Having an idea that either there's a reason we're doing the things that are so hard, we're staying home and not going to school to keep everyone safe, and really believing that, it provides some resiliency as well to deal with the negative effects of being home. Thinking about the input for kids, media exposure, whether it's on the internet, online, and in any form, or on TV or traditional media, having a sense of what kids are exposed to and time to talk about and explain it, and even limiting screen time or exposure to media can be very helpful, because you want to, as a parent, as a caregiver, you want to try to stay ahead of the input they're getting and being able to provide explanations, check in about what they're thinking and how they're reacting, and helping them deal with that. And I want to leave you with this thought from Frederick Douglass, a famous Rochesterian. It's easier to build strong children than repair broken men. This is really the motto and mantra of our Division of Child and Adolescent Psychiatry. And if you were in my office with me, you'd see that I have this picture on the wall right in front of me as a reminder every day of this message and for the work I do. Thank you for your attention. I want to ask Jennifer Johnson to join me right now as we progress to the next part of our presentation.
Thank you, Dr. Scharf, and everyone at home watching. First of all, thanks for got hundreds. This is obviously a very timely topic. We appreciate your interest. You're listening and you're submitting questions. We've had some that have come in before today, so I have a list of those, and they're coming in live over our chat as well. So I'm going to do my best to try to get to them, as many of them as possible. And again, please feel free to continue to type those in, and we'll try to get to them if we can. Dr. Scharf, I want to start with maybe a two-part question, and this is something that seems a lot of people are really asking about. When is it time to seek professional help? When do you know, you notice something's up with your child? When do you kind of say, okay, it's time to seek professional help? That'll be the first part. And then I guess the question would be, you mentioned, the backlog in some cases in getting help. You talked about the wait list, and a lot of people are wondering, I feel like it is time for my child, but I'm reaching out and I'm not getting any answer. So let's start with, when do we know it's time to kind of pick up that phone and go, okay, let's do something.
So if you're at a point where you're convinced there's a problem, that's the point to do something. Now, what something is will be different for different families, and I'll come back to that. But saying that another way, you know your child, and if your child is different than what you know, you should be curious about it and not be satisfied until you have an explanation. And even if the explanation ends up being wrong 6 months later, that's real life, that happens to all of us. But a starting point of curiosity and really figuring out, why is this different? Why does my kid's mood state seem different? And don't be satisfied till you have an explanation. But when you're ready to do something or talk to someone, is it time to go see a therapist or go to a clinic? Well, not necessarily. If you're certain that my child's having anxiety, having panic attacks, having depression so bad they're thinking about ending their life, those would be cases, yes, it's time to see a mental health professional, and to, even if you end up having to wait, to sort of get in the queue, so to speak. At the same time, or if you're not sure, there may be other resources to help you figure it out. And probably the most common one would be your primary care physician or pediatrician or pediatric primary care provider, whether they're a doctor or a nurse practitioner or a PA. The reality is, part of the youth mental health crisis we're facing is 40% of primary care pediatric visits are about mental health now. So your primary care provider for your child is already used to being the front line of answering questions about it. It doesn't mean they're going to start a medicine or be the one who treats or fixes everything, but they can help you figure it out and figure out, is this something where, maybe you could read some stuff and watch for these signs, or it's time to go see someone else. Mm-hmm. Depending on your church, if you have a youth group leader or a religious leader that is also, informed and willing to help you figure out, that could also be very useful resources.
And then applying that, if you would, to the college level for maybe kids who are back on campus and maybe their parents live states away. what do you do then? I mean, if the child's still if he still sees a pediatrician, does the parent still start there? But if not, if you're states away, what do you do?
Yeah, so you can still start with your pediatrician, and everyone is now at this point used to doing some form of telemedicine or even just checking in by phone as a result of what we've had to deal with the COVID pandemic. So again, that doesn't mean that the pediatrician will do every element of their care or even figure everything out, but as a starting point to figure out what's the threshold to refer to someone, yes, I would still think about starting with primary. If your child is at college, or even if they're not living on campus attending college, certainly every college in our region, and I always hesitate to say everything or nothing, but I believe every college has some form of a counseling center. Now, what they are able to provide and what the scope of their practice and how much they can provide varies considerably, but that can also be a starting point. Again, going through the front door and asking to meet with someone doesn't commit you to therapy forever or even mean you have a diagnosis, but they can help you figure it out. So for the college population, that would be a good service or resource to utilize as well.
Okay. Thinking even like maybe the health center on campus, for example.
Absolutely, absolutely. And again, just like primary care pediatricians and other primary care providers are used to addressing mental health conditions, that's generally true for college health centers as well.
Okay, good. That was a very popular question. We talked about, when it's maybe time for getting help. I think people are wondering how to start that conversation. Got a lot of questions about what are some leading questions that you can do to sort of maybe talk with your middle school or high school or college age student who, might not have any time for you. No one wants to talk to mom or dad or, aunt or uncle or something. But what are some questions that you can sort of, all right, I'm really trying to open this door and get them to talk to me. What are some good conversation starters to go there?
So I would start answering that by thinking about the attitude or the theme of how to approach it. And I say that for a couple of reasons. One is me telling you the exact words or script. If it doesn't feel genuine, particularly teenagers, but young adults as well, they have BS detectors. And if it seems fake, they're just gonna blow you off. So I can give you examples, but it should be your own language and really feel natural. But the theme then should be curiosity and caring. And so, as a role model of curiously asking questions, even in a overtly almost false sense of ignorance I know we have some alumni who have been around and even watching TV for a long time. For the younger audience, they may not recognize this reference, but Peter Falk's Columbo is a great example of someone doing a curious interview where, he, as an audience member, who the killer is and what the answer is, and he does too, but he still goes through this asking questions in a curious, humble way and never acts like he knows the answer. That's a theme. So ask in a curious way. I notice this. I'm really curious about it. I notice this. It makes me worry, and I'm really curious about it. That's the theme. So if it's depression, for example, if you're worried that the person's sad or isolated or less interested, you'd say, I noticed that you're not doing the same activities you used to do. I'm really curious to understand it, and it does make me worried. That would be an example. But again, it should be genuine language, use real life examples rather than abstract ideas as much as possible, and approach it with curiosity and humbleness.
Gotcha. We have on our live Q&A, we have a school-based mental health counselor in Queens. Welcome, hello, in Queens. They ask, can you provide some resources on how to conduct a suicide assessment on younger children?
Yeah, so you asked for resources. So the best short single resource tool I would recommend is the ASQ, developed and validated by National Institute of Health, and it's been validated in a variety of settings. And it's 5 questions. It's pretty simple and straightforward. There's also a Ask toolkit on the NIH website that talks about how to interpret it and how to use it. So that way, if I was giving you a resource, that's the resource I would start with. It's language-based, which would then be middle school and high school be the most comfortable asking direct questions about their thoughts. But you can still, as a starting point of the things you want to ask and cover, try to adapt it to the child in front of you. in terms of other resources, many states, you mentioned this person's from Queens, and New York is one of them. And when I was introduced, someone mentioned my introduction, remember, Dr. Schneider mentioned Project Teach. This is an example of a child psychiatry access program that about half of states have them right now. And it's a resource for primary care where you still start by accessing the primary care provider. We've had school physicians call actually, and then they can speak to a child psychiatrist for specific guidance and connection with services, so that if this is a higher need case, they're not just number 300 in the queue, but we can sort of navigate the system to get someone to their needed services as fast as possible. There's a website nationally if you're not in New York. It's nncpap.org. And when we give out resources after this, we can include that. And then for New York State, it's Project Teach NY. And that Project Teach website, you can access it from any state. The consult portion of it is for New York State providers, but there's also a number of rating scales, tools, some videos for families about supporting kids who are struggling with specific issues and helping figure out what's going on. So that's a very helpful resource.
We've talked a lot about the role of parents and parents' questions. I want to look at some other relationships. We've heard from some grandparents who kind of say, you know, what is my role here? What if my kids, the parents of my grandkids, you know, don't agree with mask usage? So sort of what is the role of grandparents in this? And then peer-to-peer, what are some ways that maybe high school kids or middle school kids or college kids can maybe support one another and provide peer-to-peer support?
Okay, so I'll start with the grandparent or interested adult who's not the parent role. First, I would think about some of the things I've already talked about can still apply. You know, when you're with a child, being curious and try to understand what they're thinking and feeling and respond. But if a parent has made an explicit rule, or you're already in conflict with that parent about rules for their child or expectations for the child, unless it crosses a threshold of abuse or danger, you need to defer to that and respect that. And if it does cross a threshold of danger, you can consult with social service agencies or, again, medical providers to try to figure out, again, this is going to be really rare, but in that extreme case when it crosses a threshold of danger. There's nothing better, though, in terms of, again, not in that danger category, there's nothing better than role modeling. And in fact, a saying I'm fond of, and I wish I knew the original source, is that your child can't hear you because the example you're setting is too loud. And you should make sure that your behaviors reflect what you want the child to learn. The best thing you can do to encourage mask use with children who are ambivalent about it is for you to always be wearing the mask and maybe even, you know, mention it or point it out. And same thing for dealing with anxiety or practicing coping skills, practicing good sleep hygiene, nutrition, exercise. If you're going to tell your kids to do it, you should be doing it too and role modeling it. And you can do that as a non-parent adult figure in someone's life as well. The next question was about peers. There are some, I guess this is sort of an answer for adults or even people who are in an administrative capacity. There are some prevention programs with you if you are in a position in a college or in a high school or in a middle school. There are some peer-focused resiliency providing programs. One which we've played a part in validating and implementing across New York is called Sources of Strength, and it's associated with decreasing rates of suicide in a teenage population. But the principles of that include having youth who have multiple social contacts, identifying how they deal with stress, that would be in the category of coping techniques that I talked about before, publicly talking about it, and then having projects they work on to build resiliency in the community, either draw attention to problems or highlight ways you can deal with problems. So even if you're not part of a big organized effort in that way, as an individual way, and in some ways it's another way of me talking about the role modeling. A peer can talk about how they deal with anxiety or distress, because those are normal things we all do, and how to deal with it effectively. Can also talk about the idea that talking to your doctor, going to the counseling center or the health center can be good ways to help figure things out. And again, the idea that I talked about in the context of parents, of being curious. If your friend's acting differently and you're not sure why and you're worried, ask them and be curious and humble. Don't tell them you know what they're thinking or that you know they're at risk of something. Just say, I want to try to understand. I'm noticing this thing. I don't understand. Help me understand.
I want to get back to a little bit of a theme we started a little bit ago, and this question's kind of a follow-up from my friend Gary. Hi, Gary. There's probably people out there who don't have insurance or a primary care provider or a pediatrician. So if you are in that category and you have a child who's, you're concerned about, you said for a lot of folks, their first step would be to call your pediatrician. If you don't have that set up, then where do you go? What do you do?
So I can say that, again, this will vary depending on where you're located, but in New York State, every child is supposed to have and does have, if they're enrolled in school, an identified primary care provider, even if they've never seen them. So, if you're in New York, for example, and this will be true in some other states, but I don't know about everyone in detail, and you're unsure, you can ask whether, if you have zero insurance or coverage, you can't do this, but if you have Medicaid or insurance, you can ask them, who's my designated provider? You can ask the school. If you really have no insurance and no identified provider, then I would suggest looking at, it's typically organized at the county level, but county or state websites for how to access emergency medical care. And that, I wouldn't necessarily show up and stand in line, but that would be the, who I would call to help figure it out. Again, I can speak to what we have in New York and in my area most effectively, but if we have a resource number, 211. If you call 211, the people that answer will help you figure out where you can really go to get medical care, even if you don't have any ability to pay for it. Now, most counties have some sort of information support like that. Are they all as good? Are they all 24/7? It does vary, but that's where I would be looking for.
You mentioned the role of government there. John wonders, essentially, are you at the table with policymakers in Monroe County as we sort of balance, risk versus benefit with this response?
Yes. So now, when you say at the table, who's at the table, which administrations, kind of changes over time. But I can say in Monroe County, certainly right now with the current administration, they're very interested in children's health. And often it is me personally, but if not me personally, it's other colleagues from the Children's Hospital who are talking about promoting children's health and resiliency in Monroe County. And I can say even in the previous administration that was true. It's just, there is the change in leadership with politics and regime changes does sometimes delay some of these things. But I can say in our area, supporting children's health on principle is not controversial and it's not political. And my voice and others have been welcomed in our region.
I want to mention, go back to the point about media. You're talking about, hearing a lot of this stuff can make adults anxious, of course, children as well. So how do you cope with media overload? And of course, we think of maybe the news on TV or the radio, but I would say in addition, we used to talk about screen time limits, before the pandemic hit, and then the pandemic hit. And I heard some of the screen time, rules, kind of throw them out the window, right? We're all sort of doing what we need to do to get through. So how do we cope with, I guess, traditional media, but also screen time and what that brings into our home?
So I'll make an acknowledgement that as a parent, and I'm a parent of 4 children, for 3 of them, this was very easy. And for 1, it's a lot harder. And so I can tell you the principles, and I acknowledge that may be hard to implement, but the principles are still true. So if you're concerned about media overload, the response is to limit it. Now, it's easy for me to say that, limit it, 2 words. It's hard to pull off in real life. And some things that we might have used in the past, like just, most computers have a way to put on a protection where you can only use it for a certain amount of time and then it logs off or shuts down. But if they have to do school for 6 hours a day and you're not there, it becomes trickier. And I know that, but still the principle of limiting the quantity should be a starting point. And if you're not even sure how, then start with counting the quantity. This is actually true for other behaviors as well. Most people, at least before smartwatches and ways that they would have reminders for them, would not actually be able to tell me how many hours of sleep they get a night. They have a general idea, they think they know, but when I ask them to actually record it and look at a clock and write it down, they'd be surprised by the results. The common factor in all the diets you might see advertised, where in any medium, is not the mechanism that they say they're going to help you figure out how to eat differently. The common factor is that you actually count what you're eating and keep track of it. Most of us don't. So same thing with screen time. If your goal is to limit it, you got to start by quantifying it and understanding it.
We are late in August. Traditional under normal years, we're talking about, how to, break back into that routine of school. Maybe the anxiety of going back to school, just getting in the routine of going back to school. Now our kids have been out of school since March, and we are heading back to not just the anxiety of school, but a school that is entirely different. So, any advice for as we're trying to help with this transition?
So. Yeah, and I know we're getting close. So again, I'll talk about principles, some of which to do well, you would have had to start a few weeks ago. I know that, but nevertheless, the principles are, first, know your kid and know your family and know what's realistic. The schools are working really hard, and I'm certainly confident saying that in our region, and I believe it's true across the country. The schools are working hard to do the best they can for everyone. And the reality is, every individual kid is not the same as every other. And so, if you have different options, like going full-time, going hybrid, remote learning, if you have the resources and are considering private school, my starting point is not to say, oh, rank order them this way, one's better. The one that's better is the one your kid actually does, right? And so certainly if it's a situation where you think a kid won't really do the plan, whether it's wearing a mask at school or doing the remote learning at home, then if you're confident about that, you're confident about it, move on to the next decision. For one of my children, in a high school setting, the number of changes in just regular pre-pandemic schoolwork was such that he would, at the end of the day, have more homework than his siblings because he took longer to sort of do the transition and sort of settle in and then pack up his stuff at the end of class. Whereas my other kids would get some of their work done during the class. I don't know if the teacher liked it, but they did. And so I had I have one kid who was an outlier in that way. When he went to remote learning, he was actually much more efficient and did the same work. And now in that case, we pushed a little because the school wasn't setting high expectations, but we found that he did much better work in this kind of way where he could control the pace and control the transition time. So if you know your child and know what makes them more challenged and less challenged, that will help guide. You also should know your family. If you can't pull off being at home and having some semblance of what's going on or trust the child to be there alone, then you can't do it. And it is absolutely okay to say that. And now the quantity of resources for this is challenging, and I don't pretend the world's figured it out, but even in districts that have gone to all remote learning, there are child care centers in our community, the Rochester Museum and Science Center, which is a museum, and the Strong Museum, the Museum of Play, have both prepared and open programs where you can come in and have your kids stay there, and they'll do the remote learning and also have adult supervision while you're at work. So those are just two examples that I know of, because my family are members in both of those places. But there are other examples as well. Some YMCAs have tried to put together similar programs as well. So know your kid, know your family and what you can reasonably do, and then find the best fit.
Along those lines, I guess, somewhat, we get into school and, we get going. This is a question from someone who says, I'm a school teacher and I'm torn between trying to be responsible and fair in holding students accountable for their schoolwork and learning, but I've experienced some pushback from students and parents about this being too much for students who are experiencing or have experienced trauma. Any tips on how to find the right balance?
Unfortunately, there's going to be some trial and error here. So I can reinforce the principles, which it sounds like you're already zoomed in on, which is, doing nothing and saying, this is emotionally hard, so I won't have any expectations or consequences. well, they'll be backsliding, particularly and ironically among the kids who are already most anxious or who are most traumatized. You could think of it as sort of a spectrum of being, accommodating versus rule driven. And if you have any distress and just kind of accommodate whatever the stress is, oh, you don't like to go to bed at this time, go to bed whenever you want. Oh, the homework makes you feel sad, don't do homework. Well, if you do enough of that, let's take out emotional things. If someone doesn't like to walk and you tell them don't walk. Well, if they don't walk for a week, it's going to be harder to walk. And this is true about academics. This is true about social interactions. It's true about all expectations and behaviors generally. You got to practice. You got to have some expectations and some pushing to see advancement. The problem is on the other end of being so rule bound that you're not even paying attention to sort of the natural feedback of a kid being stressed out in the moment, is it can become too much and become toxic or overwhelming. So how to find that sweet spot of making sure you're challenging and there's accountability and even consequences, but not having the size of them be overwhelming, that's the theme. That's the trick. How are you going to do it? I wish I could give you an exact map. It'll be different for different ages and different classes, but I wouldn't back down from the idea of having deadlines, for example, or having this is what you need to do to pass ninth grade math. Mm-hmm. And maybe we can figure out that instead of having the quizzes on Monday, we have a longer quiz every other Monday, right? You might vary some things that are not that important, but have the core requirements stay absolute and stick to them.
First of all, everyone, thank you for your questions. We are coming soon to the end, so I have one more question from Ellen. I know you have strong ties to the autism spectrum disorder population, and actually physically where your building is now, connected to a lot of those different resources. Ellen wonders, do you find that children on the spectrum are stressed out by the pandemic, maybe more than others?
So this is a tricky question as well. And so the answer is, it depends, or I could say some are and some are not, because for some kids who we might call higher functioning, less dependent on support services in their home or day to day, who are in a school program where they have frequent times during the day where their own social skill limits and capacities are challenged, or they're bullied even, or have other, just challenges getting through all the things of a day, they're actually expressing relief and that they like this better. But then people who really do need and benefit from having multiple adults be involved to support kids' day-to-day activities, maybe they need occupational therapy or speech therapy specifically, losing those supports has been really problematic and has been overwhelming for many parents. I didn't mention this in my talk, but part of that population of kids that are presenting to the hospital in more need and a more serious state, that includes a higher proportion of kids with autism and developmental disabilities who had a lot of supports. And in New York, we have a lot of supports, more than average in terms of comparing states, to keep people at home. They've not all gone away completely, but they've been severely limited with the restrictions, closures, staff limitations from the pandemic. And many parents are exhausted and overwhelmed. So it kind of depends on the kid and where they're at and what their stress points are, if you will. So for some, they're experiencing it as easier. Some, it's really a hardship for the family. And even for the ones who are experiencing it as easier, I'm worried that then it'll be a bigger step. It'll be harder to get back to previous level of activities and expectations.
Well, stressed and overwhelmed. I think you kind of summed up a lot of us right now. But always hearing your insight and your tips. Again, we have a lot of people who are very concerned about this. A lot of people, again, concerned about access. And so we appreciate your tips on all that and so much more. I think we are coming to our end. So anything else from you, Dr. Scharf, before we send it back to Dr. Schneider?
Thank you. Yeah, in closing, we talked about a variety of different topics, and that makes sense. And everyone is different, and we want to respect their individuality. But again, I chose these very almost generic seeming principles because they really do apply, whether it's a child with severe depression or a college age student who's having such a tremendous sense of loss because they're losing their imagined college experience, or a child with autism, as we just talked about. The general principles of knowing your child, of being curious when there's changes, of trying to introduce consistency and explanations for things that are stressful or distressing, and routines and role modeling. These really are the same principles for each of those populations. And I think there is every reason to be hopeful. We are learning more and more about the science, not only of what negative things do, but how to offset them with positive protective factors, as I outlined. So this is hard. It's going to continue to be hard, but I have every reason to be hopeful. And with that, I'm going to turn it back to Dr. Schneider.
Thank you, Dr. Scharf and Jennifer, for a provocative session. I'm certain all participants appreciated both the strategies and the challenges you were able to share. The presentation actually perfectly supports the university's evolving post-COVID vision, or Rochester restarts, and tends to underscore President Mangeldorf's thoughtful call that we approach this and respond with both resilience and optimism. I hope that you have enjoyed the program, and we'd like to hear your feedback. Please take a moment to share your thoughts about the session through a brief anonymous survey. The link for the survey will appear on your screen at the end of the webinar. Simply select continue to get to that survey. Also, please join us in 2 weeks on Thursday, September 10th at noon Eastern Standard Time for our next Experience Rochester lecture entitled The Future of Work, COVID-19 and the Impact on Student Career Readiness. This lecture will highlight Associate Vice Provost for Career Educational Initiatives, Joe Testani. I look forward to having a great late summer afternoon and evening today. Please stay vigilant, safe, and well. Our best to all. Bye-bye.